Okay, the webinar has begun.
Dr. Bangui.
Well, good evening, everyone. And I hope you can all hear me clearly and audibly. And welcome everyone to this third in the series of the Afran Kidney Transplant Committee webinar series. We've had two previous webinars that have turned out to be quite successful, and this will be the third in the series. This evening, we'll be speaking, the webinar is focusing on the West African sub-region, where we'll be looking at the current state and prospects and challenges of carrying out kidney transplants in the West African sub-region. And this evening, we have put together quite a number of moderators and speakers representing the countries within the West African sub-region that currently carry out kidney transplants successfully. Without much ado, I'd like to introduce Gamal Sadi to go ahead and introduce our moderators for today. So welcome, everybody.
Thank you very much for the introduction, and I believe this is a great achievement to keep following up our current situation and challenges we are facing in all regions in Africa. And the regional problems and issues are definitely peculiar in every part, and that's why we are concentrating in this very important issue. And it would be great to have the moderators of this webinar, Professor Sir Gui from Cote d'Ivoire, Professor Fioma Olassi from Nigeria, and Professor Muhammad Mah from Mauritania. And we have very peculiar speakers, and I would leave the floor to the eminent moderators to introduce the speakers and topics. Thank you very much.
So I think that we can start with the first presentation. Dr. Gay, can you introduce, please, the first presentation?
Yes, I will try to present my Professor Akundu. Professor Akundu Ngesankan Clement, Professor of Nephrology, Honorary Chief of the Nephrology Department, Cocody University Hospital, Abidjan, Chief of the Renal Transplantation Team, Abidjan, Director of National Center for the Prevention and Treatment of Renal Failure. You have the floor, Professor Ngesan.
Okay. Thank you, Mr. Chairman. Thank you, everybody, and good afternoon to you all. I am Professor Akundu from Côte d'Ivoire. All my slides are written in French, and the comment will be made in English. In fact, I'm not a good English speaker, so I would like to apologize for the many mistakes I'm quite sure to make during my comment. So it is to talk about kidney transplantation in my country, the current situations and the challenges we have been facing so far. We are going to straight into the subject, beginning by this slide. This slide shows the number of kidney transplantation we have performed since the very beginning of our kidney transplantation program, since the year 2012.
Please, Professor Clément.
Yes, yes.
We can't see your second or third slide, please. If you can share with us or change the slide.
I think
Change
presentation mode.
presentation mode. Right.
It's not a slide.
Attention. So, no. So, can you see my slide or not?
Not yet.
Not yet.
We can see the slide, but it's not in presentation mode. So you need to put the slide
You have
mode
to
and
slide
then change
mode.
it.
Comment on peut mettre en chose, en mode chose.
Voilà ce que vous devez faire, professeur
Je dois
Clément.
faire. Oui.
Il faut mettre les slides en mode plein écran.
C'est ce que j'essaie de faire là, justement.
Plein écran tout d'abord. Puis vous allez cliquer sur la présentation par le bouton droit.
Voilà, je pense que ça est compliqué pour moi là.
Non, c'est pas. Vous essayez de me suivre, s'il vous plaît. Donc, il faut mettre la présentation en mode plein écran.
Mode plein écran. Justement, je ne vois pas le mode plein écran ici, là, justement.
Non, juste en bas à droite. Il faut la mettre en mode diaporama, oui. Vous voyez près du zoom. En bas et à droite.
Près du zoom, en bas et à droite. Mais quand je fais ça, ça ne va pas comme ça. Hein?
Fermez votre présentation PowerPoint, puis essayez de la réouvrir.
Et ça, vous ne voyez pas, non?
Non,
je ferme carrément?
Oui, fermez carrément la présentation.
Ça a bien marché tout à l'heure. Il suffit de fermer et de réouvrir.
Oh là là.
C'est pas grave, prenez votre temps. Fermez votre présentation.
Il faut fermer.
Très bien. Essayez de la réouvrir maintenant.
Can we have the next presenter so that we don't keep wasting time while he sorts out the slide?
Vas-y.
Okay.
C'est toujours pareil?
Très bien. Maintenant, c'est bon.
Parfait.
C'est bon, d'accord.
Ok,
très bien. Ok, d'accord. Ok.
Très bien, ça change, hein, c'est bon.
Ça change?
Oui, vous pouvez revenir dès le début et vous commencez.
Attendez. Allô? C'est bon, là, vous voyez ça? Is that OK?
C'est bon.
Oui,
vous
professeur.
Commencez dès le début.
Dès le début, bon, dès le début, c'est là. Donc, dès le début, voilà, donc c'est ça. OK. This first slide is about is the title of my presentations. There are some slides which are useless. That's why I start by the first slide, this one, which presents the number of kidney transplantation were performed since the very beginning of our kidney transplantation program. How was that? What's about that? Qu'est-ce que c'est que ça? C'est quoi ça?
Professeur Ng,
oui, j'essaie de voir là, j'essaie là. Je suis avec
non,
mon assistant.
si vous avez besoin de quelques minutes, on peut commencer avec la deuxième présentation et revenir.
Voilà.
Ok,
attendez,
ça va pas?
Oui. Attendez 2 minutes. Je suis avec mon assistant là, qui est en train de voir ce qu'il peut faire.
Je Je pense qu'on va passer à la deuxième présentation.
D'accord. Ah, ok, passer à la deuxième présentation, tu peux passer après.
Ok, parfait.
Ok.
So, can we please
Ça.
pass to the second presentation with Professor Al-Haji Ferika? It's okay for you because Professor Ingassan had a problem with his Professor Ulas. Can you
C'est
introduce
le bureau, oui.
Professor Al-Haji Ferika?
Good evening, everyone. And good morning, everyone. I'm going to introduce the second speaker, who is Professor Al-Haji Ferika, who is going to speak to us on kidney transplantation issues in Senegal. Professor Ferika is the head of Department of Nephrology in Aristide Hospital in Dakar. Is also the head of the Department of Medicine and Medical Specialties at the Faculty of Medicine and Pharmacy. He's the president of the National Council of Organ Donation and Transplantation of Senegal, and the general Secretary General of Senegalese Society of Nephrology and Dialysis and Transplantation. So I think he's the best person to talk to us on this topic. Professor Ka, you have the floor to speak. Thank you.
Thank you all. I would like to thank all the members of the French Transplant Committee, Afran Transplant Committee for unfiling committee. I also thank all for the moderators of this session, as well as the colleague who follow this webinar. I have to tell you about the process put in place for the effective start of the kidney transplant in Senegal. I ask you, you will have to listen very attentively because my English is not very good. I am just demanding. Bon, maintenant, j'espère que je vais pas faire comme des sens, ça va avancer. Voilà. Senegal has opted for principle of guaranteeing health for all with the development of a health plan that meets the need of the population. This plan aims to enable the access to quality care for everyone and everywhere. Bon, it is aim for all African politics division. It's very good, very nice. It's a very nice aim. It is necessary to have a transplant because the latter has several advantages over dialysis. Renal transplant, you have several advantages over dialysis, including low cost, regaining autonomy, and a better life expectancy. Donc, it is very important to, when you have the hemodialysis, dialysis peritoneal, to complete this transplant program. Kidney transplant with a living or decayed donor require conditions of safety, ethics, and transparency. As the establishment of a regulatory body called the National Council for Donation and Transplantation, CNDT. It is very important because the establishment of this legislative and regulatory framework government transplant activity took several years. The first is law is voted in 2008 on the law on donation removal, organ transplantation, and EC-TC grafting. We have waited 4 years because and after 4 years we have a decree on the organization and operation of the CNDT, the council that organizes activity. Donc we have lost 4 or 5 years to establish this council. The mission of this council are to ensure transparency, coordination of donation and collection, management of the register, and coordination of international exchange, to ensure health safety and compliance with medical ethics, and to develop a strategy of communication. Communication for donation or for transplantation is only of the responsibility of CNDT, also this council. Or any hospital, any other organization, and have law to develop communication about donation and transplant. In Senegal, any health structure wishing to carry out kidney transplant activity must obtain approval. It is necessary. It is necessary to obtain approval before beginning activity of transplantation. And the CNDT is responsible for evaluating this health structure that are candidate for a kidney transplant. It's very, very important. It's you can any structure can begin the transplantation before the evaluation and the for the CNDT. In addition, CNDT is responsible for control procedure and outcome to improve the safety and quality of organ transplantation. Donc, CNDT can do the evaluate and can survey the outcome of this transplant. It is very important. Achieving this for this objective requires a cross-disciplinary vision taking into account not only purely technical aspect but also ethical, deontological, and social component, which explains the multidisciplinary nature of the component of CNDT. You have a multitude of specialists. You have doctor, pharmaceutical. You have specialists of law. Donc, it is vraiment a multidisciplinary vision in the CNDT composition. And we have a scientific committee composed of medical and non-medical specialists. And for better organization and proper functionment, the center has adopted other tools, has internal regulation, ethical charter, strategic plan, communication plan, organization manual, current legislation and regular text in the corner. Donc we have another text to complete this. The granting of approval is governed by a decree of Ministry of Health. This decree defines the conditions that any health structure must meet in terms of internal organization, infrastructure, equipment, and human resources to obtain approval for kidney transplantation. This is also a decree. The granting of approval can only be obtained after an assessment of the structure carried out by the CNDT as decreed in the 3 articles. To begin for activity of transplantation is conditioned by the evaluation by CNDT. As the evaluation have many steps. We are the important point for application for our approval. What we have many actors. Public health establishment is the first actor. The National Council for Donation, the external evaluator. To evaluate this establishment, we have external evaluator. After the Minister of Health. If a structure establishment, public health establishment wanted to have approval, they must have you have a fully complete evaluation grid. It is very important to compound every step. General information about the health establishment, so it is her organization. the administrative component, the infrastructure for transplantation, the block, the service of nephrology dialysis is needed. If you have block, how you nephrology, how you dialysis, how adopted recovery room, how you intensive care unity, how you laboratory, how you imaging, all this infrastructure are necessary. You have a qualified human resource for transplant activity. It is not sufficient to be just a nephrologist or just a urologist. You must be a nephrologist who urologists have training in transplantation file. See, it is very important to have a training in transplantation field. But see, if you have nephrologists and urologists who haven't trained in transplantation field, you will not have approval. It is very important. If you have not infrastructure, adequate infrastructure, would not have, if you not have any intensive care unity or laboratory, it is not possible to give you approval for transplantation. You meant after this, the public health can describe all the activity he do in this establishment in the area of nephrology and urology. It is very, very important. As we have activity in nephrology, you have training in nephrology, you have in your urologist unity, what do you do about kidney, as we have activity about kidney. You can report all this, but it is very important to show your experience. The resource human, it is very, very important to component of team and all technical method set up with the framework of kidney transplant. It is very, very, very important. And you can justify your training in the file of transplantation. The internal hospitalization organization and quality management. It is very important to have a quality management in this hospital. You must have a local committee for quality management in this hospital. And plan investigate what you can show what it is your plan in human resource and infrastructure in the future to permit to grow up the transplantation. It is very important. All these things is very important. Publish establishment, health establishment, good will provide this after having approval. Donc, training course, voilà, description of planning partnership. If we have a partnership, it is very important for and information of all standards of residence system file by file. And after the council, the CNDT verify this to verify to process, verify on the fail and discharge, appointments of the evaluation team in agreement with EP, signed, and we have prepared of the conduct of the evaluation. But it's the next time you will send some evaluator to evaluate this hospital. You can bring information to do about your human resource, your infrastructure, all, but it is necessary but not sufficient, because you can evaluate. You have a team evaluation. The team evaluation visit this hospital 2 days. After studying the field, go to the health structure to verify everything that has been declared in the terms of infrastructure, equipment, human resource. Following this assessment, a report is produced, including the strength, the weakness, and the recommendation for the establishment. It is very important. And after this, the council, after studying this report, the CNDT issue an opinion, maybe favorable, maybe unfavorable for theoretical approval. It is if after this, the CNDT, voilà, you may be opinion favorable. Okay, it is a good societal structure to be there. No, it remains some problem, not have enough structure. The training of the specialist is not enough. Voilà, we will be to to ameliorate this, or it's okay. We give it approval for 2 years. Approval is for 2 years for this activity. Kidney transplant process, where it is in summary the process of setting up the kidney transplant program in Senegal with the case stage. The first time is the law. After you have the council, the CNDT, where you have 4 years, and after the Minister of Health, Minister of the decree laying down approval condition for kidney transplant. And we have approval of consortium Aristide Le Dantec University Hospital and Waka Military Hospital. And the first transplant, the first 3 kidney transplant in November 23. The first kidney in November, in April, the consortium, after studying the file, go to the health structure, so where everything has been declared in terms of infrastructure, equipment, human resources. Following the report is produced, including strength. Donc, the recipient donor will be adult, including 2 sisters, 2 brothers, and 2 spouses. 2 preemptive, no complications, and the kidney function were normal at this in September 2004. And in July 2024, it is the 4th kidney transplant to do for only Senegalese team of transplantation in terms of nephrologists, urologists, nurse, all the team is Senegalese. The strength is the commitment of some of the actors, so it's very important. Want to successfully implement this program is the existence of technical platform and the political commitment. The very content, the very weakness is the financing of this activity not well defined. We have very problem with because the authorities, the politics is not yet financing this activity, and we need more formation for other team. Costing was estimated in approximately 35 years. Before implementing, we have carried out a global cost assessment based on data from abroad. The cost was estimated at $3,300 per year. The half for the immunosuppressive drug, it is very high. The hospital, all this is financed by the hospital. Hospital paid all this for 6 months, and remember yourself, until the first graft, the first transplant, this hospital support the cost of the transplantation. The Ministry of Health at the moment give nothing for this patient. Donc we are talking about to have a subvention. Thank you. It is very difficult to speak in English, but I think it is a kind of guide of information. What you do, you have the Muslim approval of transplantation, the Christian Catholic approval of schedule. Donc we have many documentation for this because we are in the country where religion is very heavy. Donc thank you very much. It is very difficult for me, but voilà, je me suis débrouillé quand même. Merci.
Okay, thank you.
Thank you very much, Professor Carr, for a wonderful presentation. I'll sit to the next moderator.
Can I, it is Dr. Clement.
Professor, it's okay for you?
I would like to try again.
Okay, so
now
we pass to the first presentation with Professor Nguessan. Thank you.
But he has to erase his slide first. Professor Farika, your slide is still on the screen. Right. Share. Let's share. Vas-y, vas-y, fais. Attaché. Vas-y. Ça. C'est pas. Is that okay? Hein? Can you see my slide? Is that okay? Est-ce que j'ai le truc là?
Est-ce que vous pouvez mettre le plein
Slide
écran?
presentation mode.
Presentation mode.
Yes.
Presentation mode. Wait again. Try to do it. Pourtant, ça se voit bien là-bas. I am in. C'est chic, ça.
I think we should go on to the next speaker.
Next, I'm sorry for everything. I'm sorry. I'm not able to put on slide mode. And okay, move to the next speaker. The time I fixed my problem. Sorry about that.
I believe you can work it with the slide mode. No, not important to have the presentation mode if it doesn't work.
And
You can proceed like this if the presentation mode is not working. We can.
okay, I'll
try.
Okay, I'll try. I try it like that.
That's fine.
That's fine. Is that fine?
Good. Yes.
Okay. Right. Okay. So, okay. So sorry for these disturbances. Sorry. So my presentation is about kidney transplantations in my country, the current situation, and I start by this slide. This slide is in fact the pathway we have traveled until we achieve the first kidney transplantations in 2012. In fact, the first law devoted to organ donations has been passed in 1993, but we wait until 2012 to have the first decree related to this law being taken, and it was precisely on January 2012, and in September the 24th, 2012, we performed the first kidney transplantations, and as you can see, the first picture, the very first picture of our first kidney transplantations, and we have been able to perform the transplantations thanks to to a professor from Brussels who stood by us for almost 6 years, training our teams in how to harvest kidney by hand assisted laparoscopy. We have been able to perform kidney transplantation thanks to the Free University, the HLA laboratory from the Free University of Brussels, and also thanks to the regional representations of Novartis laboratory. In fact, we perform kidney transplantation our own without any government involvement. And we have done so, we keep, in fact, our kidney transplantation alive because our aims is to expect the government to take over one day or another. And in 2019, the government has granted our wishes. And a decree has been taken to create a state corporation called National Center for the Prevention and Treatment of Renal Failure. And it has been headed by my mentor, Professor Nyosai at that time. And is now retired. Professor Nyosai has been once president of AFRAN, is now retired. And I've been appointed 1 year ago after a call for applications. And so far, we have been able to achieve many things. We have been able to have our own HLA laboratory, and the government has told us we expect to open a new big university hospital in the suburb of the capital, only devoted to organ transplantation and bone marrow transplantations. And this university hospital will open its doors by the year 2026. Right, so this is the pathway we have traveled till we perform kidney transplantations in 2012. The second slide describes the number of kidney transplantations we have performed since the very beginning of our kidney transplantation program. It started in 2012. The number of kidney transplantations in 2024 has not been included in the analysis. As you can see, we have performed about 84 kidney transplantations since the very beginning of our kidney transplant program. And the rate of transplantation is about 6 to 7 kidney transplantations per year. There was a surge in our activity in 2015, 2016, 2017, and 2019. This report is a single center kidney transplantation report. And in fact, we got a single kidney transplantation center with 4 transplant surgeons, 2 senior transplant nephrologists, and about 10 transplant nurses. All the kidney which has been transplanted has been harvested through hand-assisted laparoscopy. The following slide describes the complications following kidney transplantations we have performed the last 12 years. Complications are divided in medical complications in one side, and other side surgical complications. Infectious complications represent the most important complications as medical ones. Bacterial infection, urinary tract infection with multi-resistant bacteria, some case of viral infections, case of CMV disease, case of COVID-19, and some case of BK virus septicemia. One case of toxoplasmosis in a pregnant woman has been described as a parasitic infection. Fungal infection comprise one case of cytoplasmosis, 2 cases of candidiasis, and 2 cases of Kaposi sarcoma. Diverse other medical complications are as follows: abdominal pain due to calcineurin inhibitors, and also blindness may be attributed to calcineurin inhibitors. There are complications such as post-transplant diabetes mellitus, cerebral vascular accident, myocardial infection, non-primary infections, non-primary function, and rejection. Surgical complications are as follow: necrosis of lower ureter, some case of sexual release, some case of stenosis of lower ureter, and some case of lymphoria. This slide, in fact, relates or is devoted to the main characteristic of recipient and donors. The mean age of the recipient at the age of transplantation was about 45 years old. They were mainly males, and patients originate a majority from the Ivory Coast, and some 30% of the patients came from neighboring countries. Hypertension, chronic glomerulonephritis, diabetes, and HIV represent the main cause of end-renal and stage renal disease. Some of our patients, 20% of our patients were immunized. Some of them presented with some DSA. Induction therapy comprised basiliximab in the most of the case, and the maintenance therapy is done mostly with tacrolimus. As far as donor concerned, the mean age of donor at the time of kidney transplantations was 37 years old. There were many males, and they were related in about 70% of the case. The present slide shows you the overall survival of our patients during the 10 years of activities. At the first years, the patient survival was about 94%. At 5 years, 75%, 10 years, 60%. Some factors have been found to be related to this survival of our patients. Mainly when the patients are under tacrolimus, the survival sounds less better as compared less better as compared to patients under cyclosporine. The other factor we found to be associated with patient survival is the number of blood transfusion the patient has had at time during dialysis. When patients is transfused more than 10 times, is likely to display a worse outcome. This slide is about graft survival. The overall graft survival at 1 year is 88%, at 5 years 78%, and at 10 years 68%. No clear factor has been found to be associated with graft survival. And the last slide concerning the current situations is devoted to the cause of death of our patients. The main cause of death of our patients are infections. Infections represent 54% of the cause of death in our patients. Among these infections, 80% were due to COVID-19, and other non-COVID infections, 36%. Some case of cancer or myocardial infarction has been reported. As far as graft loss, cause of graft loss concerned, mainly the main cause of loss are in fact so when patients stop their medications, and in fact they experience rejection afterward. They stop immunosuppression for two reasons. The first one, because of side effect of the side effect of calcineurin inhibitors, mainly abdominal pain, severe abdominal pain related to calcineurin inhibitors. And the other cause of stopping immunosuppression is due to the fact that patients could no longer afford to pay the treatment. And this represents about 26% of the case. There were some cases of primary non-functions in 11% of the case, and in 11%, in other 11%, the cause of loss were due to immoral rejections. So in total of this first part of my presentation, I can say that the volume of kidney transplantations from living donors is not big enough. Is not enough. After 2 years, just only 84% has been transplanted. This is not enough. And complications after transplantations are common and mainly due to infection. A particular complication is abdominal pain due to calcineurin inhibitors. And also a peculiar complication is blindness due to, maybe due to calcineurin inhibitors. During all my time of training in Europe, I've never met such complications. The other thing we can say to summary the first part of my topic is that survival of the patients is less better as compared to survival of graft patients of the graft. In fact, many of our patients die with a functioning graft. And also, most of our patients indeed die with a functioning kidney. And at last, infection represents the most cause of death of our patients. That's the summary. This is the summary of my first part, the first part of my presentation. Concerning the challenges, there are some challenges we have already met. In fact, we already got a legislation devoted to organ donation, organ and tissue donation since 1993. The legislation is very old and it has to be updated. The second challenge we have already met is that we have been able to perform the first kidney transplantation our own without any government support. This is indeed important for us. This has opened indeed a new horizons for a better future for nephrology in our country. Since, as I have told earlier, a big new university hospital is being built and open its doors in 2 years' time. We have been able, since the creation of the National Center for Prevention and Treatment of renal failure, we have been able to have our own HLA laboratory. We are able to perform everything: cross-match testing, HLA typing, and search of DSA. We have been also able to have from the government the subsidizations of renal transplantation costs from $2,000 to 5,500 USD. This is a big achievement, and I would like to thank my government for being attentive to our request. This slide shows the challenges we need to meet. We need to have a new legislation to update the first one. We need to include in the new legislations the notion of presumed consent if you want in the future to perform kidney from cadaveric donors, and this is important. And also, I would like to make an appeal to my fellow transplant nephrologists of West Africa. It's in my mind to tell to my fellow to have to elaborate a common legislation for all the West African countries. In fact, we got the same, more or less the same populations. Our populations have share the same, more or less the same habits, the same custom, the same traditional belief. It won't be bad if you could sit together and write something to put before a government. This will be in prelude of kidney transplantation from cadaver donors, and in case we would like to make some exchange, to make some organ exchange. It's important. It's important to think about the cadaveric donations, because despite large family in Africa, family members don't donate their organs. It's very difficult. The family members are not fully engaged in the process of donations. They are not keen to do it. And this is difficult. We cannot expect to have a flourishing kidney transplant program from living donors only. It will be, in my mind, it won't be possible. Well, that is what I would like to say. But before closing my speech, I would like to pay some tribute to 4 persons. The two first one are my mentors from Europe, Professor Abramovich from Brussels and Professor Murad from Montpellier, who guide my first step in the transplantation field. I owe a lot to them. I would like also to thank the surgeon from Brussels who helped us starting our kidney transplant program. He remained with us 6 long years. Sometimes he traveled at his own expense. He accommodated himself, paid food himself. He stood behind us. He did an outstanding work. He's a very talented surgeon. I'm grateful to him. My country is grateful to him. My team is also grateful to him. I would like to pay tribute to someone I don't know very well. It is about Dr. Bamboy from Nigeria. In fact, I met him for the first time in 2009 in Dakar. A meeting has been summoned by Novartis Laboratory. It was about to talk about kidney transplantation in West Africa. He has been the only one who has made a presentation on kidney transplantation. At this time, I was indeed amazed by the presentations. And by this time, I have vowed to make kidney transplantation in my country. In fact, it came to the conclusion that kidney transplantation is possible in tropical countries. In fact, you get transplantation from the beaten track. I would like to thank him as he is a pioneer in West Africa. And he is also an example we need to follow. Thank you very much.
Thank you, Professor Ingasan, for your presentation. It was very clear. Now, I think that we should start with the third presentation. Professor Ma, can you introduce, please, the speakers? Thank you.
Okay, thank you very much, and good afternoon for everyone. I am very honored to participate to this webinar, sharing experience for West Africa in kidney transplantation. So I introduce my colleague, Dr. Abdulatif Sidi Ali. He is assistant professor of nephrology in the University Medicine of Nouakchott, and he was the past head of service nephrology in Nouakchott, and he is the first president of the Mauritanian Society of Nephrology, and actually he is the president of the Council for Organ Donation and Transplantation. Abdulatif, go ahead.
Thank you. Thank you, Professor Mohammed Ma. It's good. Thank you for the invitation. I would like to thank the Transplantation Committee for this important initiative to develop transplantation in our country. I will address today's topic, kidney transplantation in West Africa. We will examine the challenge and the current situation in this area, and particularly the situation in Mauritania. CKD is not just a local problem, but a global public health issue. I have witnessed the increasing prevalence of CKD, and it is clear that need for early intervention is essential. We must focus on awareness and prevention strategy to manage this growing burden. Chronic kidney disease is a global public health problem, affecting 7.6% of the French population at CKD stage 3. The prevalence of kidney disease at the general population is 13, surpassing diseases such as diabetes and cancer, with 5.7 million patients living with CKD in France. The kidney transplantation offers patients a better quality of life, fewer cardiovascular risk, and longer life expectancy compared to dialysis. It's not just a medical intervention, it's a life-changing solution that also lowers overall treatment costs. Promoting kidney transplantation is the most sustainable way forward. The financial benefit of transplantation cannot be overstated, with dialysis costing 25,000 per person annually, compared to 30,000 in the first year of transplantation and 5,000 thereafter. It's clear that transplantation is more cost-effective in the long run. This economic angle is critical when advocating for healthcare investment. Over time, we have seen significant improvement in the survival rate and functionality of kidney transplant. The slide reminds you of the progress that has been made in this area and how our patients are benefiting from this advance. On the graph, we see the 10 years survival of 17%. The slide shows that dialysis in kidney transplant began a long time ago in the Maghreb, but Sub-Saharan Africa and Mauritania much more recently. Sub-Saharan Africa faced many challenges in kidney transplantation. With limited center and resources, we perform only 1% of the total transplant worldwide. Our transplant recipients tend to be younger than their counterparts in Europe and the US. One of the biggest challenges remains adherence to treatment and aqueous follow-up. This is where we need to focus to improve outcome. There are barriers to report and invalid cost of surgery and immunosuppressive treatment, political instability, low number of trained nephrologists, urologists, and other necessary specialists, lack of investigation, HLA tipping and cross-match, drug level dosing, graft biopsy, etc., etc. Some countries have just started the kidney transplant program, like Zambia in 2018, Cameroon in 2021, Senegal in November 23, and most recently Mauritania in July 2024. CKD in Mauritania. In Mauritania, CKD is major health issue with a high mortality rate and increasing number of new cases. We must work to strengthen our healthcare infrastructure and public health policy to address this growing epidemic. I estimate to chronic dialysis patient and 1,200, and prevalence is estimated 341 cases per million inhabitants. The cause visit most frequent in high blood pressure, diabetes, and obstructive neuropathy. In 1996, the first hemodialysis center in Mauritania was a major milestone in the country healthcare system. It provided much needed relief to patients, allowing them to receive treatment locally rather than traveling abroad. This center marked the beginning of significant shifts in how we manage kidney disease, improving patient outcome and reducing the financial burden on family and healthcare system. The slide shows the photo of the first dialysis in Mauritania with the Mauritanian medical team in 1996. Today, we have more than 20 dialysis centers throughout the country with 1,200 dialysis patients fully covered by the state, therefore free for patients in the public and private sector. Creation of the Mauritanian Society of Nephrology in 2012, and the first Congress in Somanef in 2050. Today, we have 13 nephrologists and 3 is training. Sorry. We also organized the Maghreb Nephrology Congress in January 2023 in Nouakchott. Experience of kidney transplant program Mauritania. Our kidney transplant program has come a long way, especially with the legal framework we established it in 2016. We have partnered with countries like Egypt and France to make transplant more affordable and accessible, and we're seeing the results. Several children and young people transplant since 2018, thanks to this network at almost 3 times less expensive than in Europe. And several Mauritanians have been transplanted at Grenoble University Hospital in recent years. It's a Cairo, children Mauritanian. Our cooperation with Algeria, particularly with the Batna University Hospital, is a model of successful collaboration. This partnership allowed us to carry out the first kidney transplant in Mauritania. Batna University also performed 700 kidney transplants in 10 years. We started this cooperation following the convention and framework agreement signed with Algeria in February 2024. The convention between the Minister of Health, Nahamet Mouklas, and the Minister of Health of Algeria, Abdelhak Saihi, in the field of health, training, hospital, and drug. And a framework agreement between the President of CNDT, National Council on Transplantation to Mauritania, and the General Director of ING, National Agency of Transplantation to Algeria, in the presence of the Algerian Ministry of Health. Strong of framework agreement, we've established a 4-step plan that includes surgeon training, conducting transplant, and providing ongoing support. The steps are essential for developing a sustainable transplant program in Mauritania. The surgeon training in Batna is a priority. By April 2024, we will have performed 6 transplants in Batna, including 1 on child. This practical experience is valuable for our medical team and represents an important step in our journey. Step 2, successful transplant of a Mauritanian couple in Mauritania, in Batna, an 18 years old girl with her 25-year-old brother. Event nephrologist participate in the operation. Arrival of the Algerian delegation checkpoint stock of the process after visiting at the hospital to Nouakchott. The choice of seat was the National Cardiology Center. Visit to hospital and National Health Center. A restitution is the choice of seats is CNC, Centre National Cardiology Center. But immunosuppressive treatment is key to transplant success, and our agreement with CAMEC and authors ensure that patients have access to TASE life-saving medication. I'm proud of the progress we've made in securing TASE resource. First kidney transplant on 26 July 2024, we performed the first kidney transplant in Mauritania. And the team, Mauritanian team and Algeria. This was a landmark achievement made possible by the collective effort of our team and the political will to support this initiative. Visit to transplant couple by the President of Islamic Republic of Mauritania reflects political will in the program. Our work is far from over. We have upcoming mission in Batna in 13 October and Nouakchott 24 November, inshallah. The training program in France is continued education and collaboration are vital to our long-term success in building a robust transplant infrastructure. Our first kidney transplant service in Mauritania is underway and it's fully equipped. We expect the official integration by the end 2024, which will mark a new era in our healthcare capability. The transplantation is not just about cutting-edge medicine. It's about generosity, solidarity, and saving life. It's a societal project, and I urge all of you to continue working together to make this vision a reality. Thank you for your attention.
Thank you very much, Dr. Abdoulatif, for this clean presentation.
I think Dr. Gui should kindly introduce Dr. Samson Antwi.
Thank you. I have the honor to present the Professor Samson Antwi, Professor of Child Health and Pediatric Nephrology at Kwame Nkrumah University. Je dois patienter. Professor Samson.
Yes, I'm trying to share my screen. Thank you for the introduction. Please, is my screen showing? Please, is my screen showing?
Yes, your screen is showing,
Yes.
but it's not in a slide.
It will come.
View.
I'll
Yeah.
put it in slide mode. It will come.
It is in slide view now, I think.
Okay, so thank you very much. And good evening to our listeners and good evening to my co-panelists. So I'm Samson Entry. As I was introduced, I'm the president of Ghana Kidney Association. So I'm presenting this for Ghana. I've chosen to title my presentation Ghana's Transplant Journey. Ghana's Transplant Journey. And so like we know, before you get to transplant, you need to have a CKD and of course, dialysis and all that. So I'll cover all that in the shortest possible time. I have no disclosure to make. This will be the outline of my presentation, the burden of kidney disease, Ghana Kidney Registry, and historical perspective of kidney replacement therapy in Ghana, growth of nephrology, and then what is happening positively in Ghana, and then our transplant challenges before. This is the hospital I work, Konfanochi Teaching Hospital, affiliated to the Kwame Nkrumah University of Science and Technology. Of course, because this is international webinar, so I thought to show a map of West Africa and Africa. So as you may be aware, Ghana, we are in West Africa, and we are emerging economy like most West African countries. We have 30.8 million people. That was the population census of 2021. And our country is divided into 16 administrative regions, as shown. Overview of CKD. So as we all know, Africans succumb to end-stage kidney disease quite early than their European counterparts. And kidney replacement therapy is either unavailable or unaffordable. And so in most places, when one develops end stage, it means a death sentence, and particularly in Africa, children. And so CKD has just enormous toll on premature mortality, also on cardiovascular mobilities. These are just prevalences across Africa of CKD, quite significant. And then, yeah, so these publications, KZ just putting CKD prevalence 15.8 in Africa, and AJ putting the CKD prevalence in Ghana at 13.3. So AJ also published this, that's very interesting, about a trend in renal disease mortality, autopsy report. And so you could see from this figure that autopsies that were performed on people who died, those due to kidney disease gradually increasing, which is in tandem with the global burden of increasing kidney disease in the world. Yeah. And in Ghana, we have set up a kidney registry in 2017. And the first report that was reported by Boima, we have then 687 patients. I think this was published. And out of that, far majority of them, 92.7, were hemodialysis. And only 2 patients, constituting 0.3, were CAPD. And then at that time, the number that had transplant was 3.5. That is from our registry. But from our registry, I think this slide is very important. It should be a concern for all of us. So this our registry published by Boima is telling us about the age that is affected by this menace of CKD. And so you can see that from our registry, The people who are affected by CKD are 19 years to about 69, thereabout. If you compare this, just suppose this with the UK renal registry, those who are affected, largely 60 years to about 85. So it means that we are dying very young from CKD. That is a much concern to us, and it is true. You see a lot of young people coming with CKD, and sometimes can't establish why, what is causing that. And say from our registry, it is interesting that majority of the people who had a CKD was due to hypertension. Hypertension was the number one cause, 37.8%, followed by those we couldn't find a cause uncertain or not stated, 28.5%. Then in that report, diabetes was just 9.2%. Then glomerulonephritis, 7.7%. Then the rest continue. But I think what is worrying, the young age, and also those CKD of unknown etiology from our registry is quite worrying. So now we look at the historical perspective of kidney replacement therapy in Ghana. We have got a very long history of starting kidney replacement therapy. As I was listening to the other countries, we started long ago, but our progress has been very slow. So really, hemodialysis started in Ghana in 1972, more than 50 years ago. But I think we haven't really progressed very fast, except that the prospect is not so bad, which I will show you. And at that time, in 1972, we had 3 adult nephrologists, 1 located to UK. And so we had 2 remaining for a very long time. We had only 1 dialysis center in the capital. From 1972, it was in 2001 that a second dialysis center was opened in Kumasi, where I work. So you could see the lap time, and our progress was quite slow. But I think we are not doing badly. What is happening? So from 1972 to 2000, we had only 1 dialysis center with 3 nephrologists. 2001, a second one was open, so we have 2 dialysis centers. 2015, we then had 6 dialysis centers. 2018, down to 15 dialysis centers, 8 nephrologists then. 2022, then it increased exponentially to 43 dialysis centers, and we had 15 nephrologists. And at that time, we had a lot of people who are undergoing training. So 12 people were training, and the training is local. It is happening in Ghana. And currently, we have 51 dialysis centers, 16 nephrologists. We have 19 nephrology trainees locally. So our progress was slow, but I think the prospect is not so bad. Wow. Slide is not moving. Okay. So then just to show you what was published 2015, and we had only 3 public and 3 private dialysis centers. And 2018, it has jumped to 15. So a slow progress, but not so bad. So as at now, we had more than 1,100 patients on hemodialysis in Ghana. Only 2 patients are on chronic CAPD. So basically, it's AD program we do. For children, we don't have a chronic dialysis program, but we do a lot of PD for acute kidney injury. We have more than 300 children who have been dialyzed acutely, and about 70% of them have been saved. But we've just set up a center for chronic peritoneal dialysis, chronic HD for children in my center, and currently we have just 4 patients on that. When we come to transplants, so this is the story about transplant. Transplant started in Ghana, in Kolebu by Charlotte Osafo in 2008. So that is a very long time ago. And with support from UK, University of Birmingham, they have a transplant link community. So at that time, I think 3 or 4 patients were transplanted in country. And it has continued to grow, but not at a very fast pace. I must say that. In the country, it is only live donor, kidney donors donation. That's a program that we practice. I will explain why. So it's only a live donor kidney transplantation. And as at now, even though these transplants are taking place here and there, we haven't really got a sustainable national transplant program. We are working very hard to get that one. And kudos to those who presented, having gotten this. Senegal started, they got this. I'm so proud of you that we got a national transplant. We haven't got that yet. So the current statistics I've talked about it, hemodialysis, transplant. As at now, 31 people have been transplanted. We are still developing. I'll come to the detailed ones, and I'll talk about just children. So Kolebu from 2008 to 2019 did 21 transplants. And at that time, the statistics was that 1 year patient and graft survival was 95.2 and 90.5 respectively. And 5 year patient and graft survival 76.2 and 71.4 respectively. And like I've said, all the donors can do in good health. And but to date, as I'm speaking, we've done this 28 transplant done, and the centers have moved. We have now got 3 centers that perform transplant. It's not a very big program, I must say. What happens is that a lot more people travel outside Ghana.
Hello? Is it me? Looks like my network has gone off.
No, I think it's general. Dr. Anthony, hearing you.
Can you hear him? Because I can't hear him.
No, I think all of us can't hear him.
Okay, so we lost him. I was wondering if it was from me.
Yeah, he's just dropped off. Maybe he'll try to join again.
He's back.
Oh, I went off. I didn't realize. I apologize. Wow. Please, can I be told where I went off? I didn't realize that. I was still talking.
I think it was about the point where you were describing the current situation of transplants.
Oh, okay. Okay. So let me just go back quickly. Okay. If I show this slide, kidney transplantation that was started in 2008 by Charlotte. Did I got past here?
Yes.
Okay, fine.
This one.
Next slide. Yeah, this one.
Okay. So
Next
this is
slide.
just giving us. Okay, fine, good. So the journey I've said that Kolebu started in 2008, and as of 2019, when the publication was done, from our registry, they've transplanted 21 patients. 1 year patient and graft survival was 92.2 and 90.5 respectively. And then moving on, 5 year patient and graft survival was 76.2 and 71.4 respectively. And in Ghana, all donation is live donor. And of course, all those who did a kidney donation are in good health. But to date, as I speak, we've done 25. This is for Kolebu. Kolebu, since 2008, 25 transplants have been done. That's the largest center. And what happens is that most people in Ghana actually travel outside the country, mainly to India. So we have more people traveling outside for transplant than probably what is done in-house. This publication is just trying to, publication by Charlotte was just telling us when transplant started, as I've shared already. And I think this data has been shared already. Centers in Africa that have done transplant. This Charlotte, at that time, Ghana, only one transplant center, 21 had been done, or at Kolebu. And but we have moved on. So apart from Kolebu, in 2000, just last year, we have got 2 more centers in Ghana that have also undergone kidney transplantation. One is the Bank Hospital. Incidentally, Charlotte, who was in Kolebu, has moved to the Bank Hospital. It's a private hospital, of course, owned by the Bank of Ghana. So last year, they did 4 transplants with support from Apollo Hospital, India. And at the same year, another hospital, University Hospital, called University of Ghana Medical Center, also last year, also did 6 transplants. Also collaboration with a transplant team from India. So now, besides Kolebu, we've got the Bank Hospital and the University of Ghana Medical Center also doing transplant. And so this is the Bank Hospital transplant team after they did that transplant. Charlotte, somewhere there. Charlotte is here and the team. And then this is the University of Ghana Medical Center when they performed 6 transplants last year. And that is with the team. So positive developments in nephrology in general in Ghana will be ending very soon. Of course, even though we are a long country, first country in sub-Saharan Africa, but I think in terms of nephrology, we are just probably toddlers. So we formed Ghana Kidney Association in 2011, so it tells you that we are still young when it comes to nephrology, even though dialysis started in 1972. Of course, after we formed Ghana Kidney Association in 2011, we hosted the AFRAN 2012 successfully. Since then, we have got a national registry in place. And importantly, also, we have got local nephrology training, both for our postgraduates, National College, Ghana College of Physicians and Surgeons, and also for West Africa College of Physicians. So we've got training, local training for both adults and pediatrics. And that is why when I show you the statistics of nephrologists in Ghana, I show you the number of trainees. They are all in country. So hopefully we can actually show our numbers. Beyond training nephrologists, we've also gotten Ghana College of Nursing and Midwifery to establish nephrology nursing training in Ghana with the help of Ghana Kidney Association. So we've also got nurses who are training locally in nephrology nursing. We think all these are very good prospects for nephrology care in the country. Another positive thing that is happening in nephrology in Ghana is that the adults don't do a lot of PD, but there's the talk to also introduce CAPD. We do a lot of PD for children, for AKI. And now we have gotten a local pharmaceutical company who has received approval, is now beginning to produce PD fluids locally. And so that is very positive for us. And I'm sure that the next time probably we'll do a presentation, we will see growth of CAPD also in Ghana. Another good thing that was happening is that just June this year, the government of Ghana announced subsidy for hemodialysis services. Before then, everything was borne out of pocket. And if you are a child less than 18 years, you have 2 sessions a week And of course, for the adults, it's so bigger, but that is a start. They only offer you 2 dialysis sessions in a month if you are more than 18 years and young. The government is set up a very big block that they call nephrology urology block at Kolebu, which is going to be commissioned very soon. And I think it's going to actually strengthen infrastructure for transplant, that particular unit that's in block. And after years of skill transfer from our collaborators from outside, local expertise has been built. And I can tell you the next slide I'm going to show. We have had this first ever transplant that was done wholly by Ghanaian team. So that's very positive. And we think that as we get legislation and other structures in place, we will be able to actually do more transplants locally also. My slide is not moving. What is happening? I apologize. I haven't got a very strong. Yeah. Okay. So challenges. So dialysis affordability is an issue because it's born out of pocket, and so there are more people who can't even initiate dialysis and they die. That is the sad state. Even though the cost is relatively cheap, about 50 USD, you know, most people cannot afford it. And human resources, a program, I've said that we have few nurses, but now we are getting local trained nurses. Transplantation, we have very limited infrastructure in terms of laboratory. All these transplants have been done here. We need to work patient out. Of course, when it comes to radiology and those things, we have a full spectrum here. But things like doing the tissue transplant, the tissue typing and the rest, we always have to send samples outside. And also even getting nephropathology is also a big challenge. So I think that is an area we need collaboration. Human resource, of course, transplant surgeons and the rest, even though the capacity is being built. Availability of transplant, because around 20,000 or plus. So that is a challenge. Hopefully, we can actually get some subsidy or sponsorship from government. I must say that despite all that we have done, we haven't really gotten our legal framework in place. That document is sitting with the Ministry of Health, and we are working very hard to get the government to get this framework in place. That will actually open the way for getting a proper national transplant program in place. So the challenges are mainly lack of institutional support, people pay out of their pocket, legal framework, I'll talk about it, limited infrastructure, we haven't got the laboratory, we haven't got the pathologists, and of course, low transplant rates. And so we rely on dialysis because the number of people who need transplant are more than probably we can afford now. I haven't got adequate surgery, even though the scale is being built. The cost, I'll talk about it. Immunosuppressants, difficult to come by. We need to get brand ones from other places, and they're expensive, as you know. So these are some of the challenges we face. What's the future for Ghana? Working very hard to get the legal framework. That's what I can assure you. I'm sure by next year we get it. We are not being this election that is coming because we are pushing very hard to get it passed this year. And I must say that the legal framework is not only about kidney transplant. We have got all the other specialties. Ophthalmology is on board. Pathologists are on board. We need to get that so that we can do not only kidney transplant, other transplant, cornea and liver and things like that. We will continue to collaborate with overseas teams to build local capacity, and we need to build the transplant infrastructure. Laboratory is a major problem. Histopathologists, people, histology, those are very key ones. We haven't got it yet. We always send the samples outside. And I think that we need more intra-African collaboration. We need that. And some people are a bit advanced. Our North African colleagues are excellent. And I think Afran should look at this so that there can be clear pathways. Even instead of probably people traveling to far away Asia, if we can get clear pathways, maybe within Africa, apart from building the local capacity, people can also be supported to do transplant, let's say in North Africa and things like that. So in conclusion, I must say that Ghana's transplant journey has been quite slow, very slow. If you look at when we started dialysis in 1972, transplant first 2008, yet the numbers we have had now, so slow, I think only 31. It is a bit slow, but there's a very good prospect with a renewed interest from all the other specialties. Transplantation is saddled by major challenges, affordability, and many other things. We need to invest more in the education and treatment help the health workforce. And we also need a multifaceted approach to address these challenges. So thank you very much. This is where I end my presentation. Thank you.
Thank you very much, Professor Antwi. And it's now left for me to introduce Dr. Ebumba Boye. I'm sure we all know that name. It rings very loud to everybody. Dr. Ebumba Boye is head of nephrology at St. Nicholas Hospital and the clinical director of that hospital. He was the first person or the pioneer of transplantation in Nigeria, and I think in West Africa. He has been in transplantation since 2000 and this must be his 25th year. And since he started transplantation, he has done over 400 cases. He is so well versed in transplantation and nephrology, and we look up to him when it comes to transplantation. So, Dr.
Well, good evening, everyone.
Ebon.
Yeah, thank you, Professor Lassie, for your kind introduction. And good evening, everyone attending this webinar. I bring you greetings from Nigeria, particularly greetings from Lagos, where I am based, and from my hospital, the St. Nicholas Hospital. As you heard, we started our journey with kidney transplantation as far back as the year 2000. So we'll be celebrating the 25th year of our starting transplants in 6th of March next year. So far, we've done 427 transplants. So over the next couple of minutes, I'll be taking you through an overview of transplantation in Nigeria and comparing it with what happens with the rest of the world. And of course, focusing on some of the challenges that we face, and then looking at the prospects and suggested solutions. And if I have a little bit of time, I'll go through our own experience at St. Nicholas Hospital. Now, transplants have been available now for 70 years. In fact, by the 23rd of December, it will be exactly 70 years since the first transplant was done in the United States of America. And despite that, you'll find that Africa is lagging behind. Even though we constitute almost 18% of the population of the world, in transplantation, we contribute only about 1%, both in dialysis and kidney transplantation. Specifically in the year 2021, we did just 1% of the kidney transplants that were done in the whole of the world in that particular year. And the reason is not far-fetched. This is a study that was done by Mudiai, which was a global study to assess availability, accessibility, affordability, and quality of kidney transplantation. And the conclusion of that study was that there is a strong relationship between the economy and your capacity to be able to do transplants. And in fact, if you plot a graph of GDP per capita and your capacity to do transplants, it's almost like a straight line graph. This is more than exemplified by this chart, which shows the top 10 countries, top 10 richest African countries by overall GDP in the world. And this is World Bank data for the year 2021. And you find that those top 10 countries are also the countries in which kidney transplants are currently being done, particularly in sub-Saharan Africa. Now, we need to realize that West Africa has the highest prevalence of CKD in Africa. And this chart by Zokali reflects the varying percentages in different regions. And you find that the highest percentage, of course, is in our region, the region we're discussing this evening, which is the West African sub-region. And increasingly, we're coming to realize that the reason why this might be is because of the inheritance of the apolipoprotein 1 gene. And you find that there's almost an exact correlation comparing the prevalence of that gene and the high prevalence that we found, particularly in the west coast of Africa. More so in these two countries, Ghana and Nigeria. And this is a study that has been done by H3 Africa. And I believe that there are at least two people on this call who have been part of this study, particularly Professor Ifeoma Ulasi, which shows that the prevalence is quite high. More so that it's now been realized that whether you have the heterozygous or the homozygous inheritance of that apolipoprotein 1 gene, your risks of developing chronic kidney disease are much higher than in those who don't inherit the gene. Nigeria, of course, we know is a federal republic, sits in West Africa. The capital is Abuja, and the financial capital is in Lagos, where I am based. We happen to be the most populous country in Africa, and our population now is over 220 million, with a very rapid growth rate and a median age of 18, indicating a very young population that we have. End-stage renal disease is pretty common in Nigeria, and we believe that the incidence of chronic kidney disease advancing to end-stage renal disease is about 22,000 new cases every year. And the prevalence based on that should be about, at the rate of 465 per million population, should be about 95,000. So we find, however, unfortunately, that the total number of patients currently being dialyzed in all the centers, and there are about 250 dialysis centers in Nigeria, are less than 10,000 on the whole. So what are the reasons responsible for this? These are common to most of the countries in sub-Saharan Africa, particularly. Problems of economic deprivation, unstable governments, inconsistency of health priorities and policies, and rapid population growth rates and illiteracy. So we find that, unfortunately, unlike when we compare ourselves with other regions in the world, we have the list in terms of the numbers of the capacity of nephrologists, particularly, to be able to provide this care. Whilst Europe has about 31 nephrologists per million population, in Africa, we have just about 1 nephrologist looking after about 1 million of our population. And the little that we have, we're now also, in fact, also losing. This chart looks at the number of doctors practicing in the United Kingdom who trained outside of the United Kingdom. And you find that in terms of numbers, the third in terms of numbers is doctors that emigrated from Nigeria. And there are over 10,000 Nigerian doctors trained in Nigeria currently practicing in the United Kingdom. Similar, ditto in the United States of America. And these are specifically nephrologists. These are licensed nephrologists practicing in the United States as at the year 2020. And you find that the number of Nigerians there is as many as 124, with about 91 from Egypt. Meanwhile, how many nephrologists do we have practicing in Nigeria? As at, I think this chart was from 2022. We have a total number of 230. So we have almost the same number practicing outside as there are practicing within the country. So to prepare this presentation, I sent out a survey to all the transplant units currently carrying out kidney transplants in Nigeria, and the responses are what I will be going through very quickly now. Currently, there's 16 units that have successfully carried out kidney transplants. Of these 16 units, 10 of them are based in public financed institutions and just 6 in private institutions. The total number of transplants done so far is a little under 2,000. All of them have been live donor kidney transplants, and most of them have been a mixture of both open and laparoscopic nephrectomies for the donor. But what you'll find, as the subsequent slides would reflect, is that most of the public-based programs are small and carrying out limited numbers. So the 16 hospitals currently that have carried out kidney transplants are listed here and listed in the order in which they commenced kidney transplants. But you'll find that despite that number, these numbers are skewed. And you find that most of them are in the southwest part of the country, but especially in the financial capital and the political capital of the country. So 4 out of those centers are in Abuja, and 3 of those centers are in Lagos for obvious reasons. So you find that most of the other centers just have one transplant center representing or with the capacity to be able to carry out transplants. In terms of the numbers that each of the centers have done and when they commenced, I think what stands out there are 2 of the centers that commenced, one in 2012 and one in 2015, that have carried out quite a significant number of transplants. So this slide reflects the total transplants carried out till date by each one of those 16 transplant units. The leading center, of course, is Zenith Medical and Kidney Center, which is based in the administrative capital of the country, which is Abuja, followed by St. Nicholas Hospital, my hospital, and then followed by Caroline Medical Center, which is based in Abuja as well. So you find that of these 16 centers, majority of them, particularly the ones that are based in public hospitals, have carried out minimal numbers, but more importantly, have carried out no transplants in the preceding 3 years. So in the last 3 years, these are the number of transplants that have been done by each of these individual centers. So what this suggests is that the privately run dialysis units appear to be the ones that are more successful. These centers are situated in the urban, highly populated and enlightened and economically endowed cities like Lagos, Abuja, and Kano. And most of them have a person who drives that kidney transplant program in each one of these centers. The problems that the public institution-based centers have been adduced to the fact that they're either understaffed or in some instances overstaffed, problems with maintenance, problems with attitude to patients, and very often interdisciplinary rivalry between various professions. But more importantly, also recurrent incidents of strikes and work to rule that bedevil the practice in many of these public institutions. So what are the challenges that the various units have had? One has been the local availability of HLA typing and cross-match. But currently, there are 3 centers within the country that have the capacity to be able to carry out this vital test that is required in preparation of patients towards transplants. The local availability of drugs, till date, all of them have to be imported, and they remain significantly expensive. The presence of adequately skilled and experienced transplant surgeons, and now quite a number of the units have local capacity to be able to carry out the transplants without the need for outside assistance. Capacity to be able to do the drug levels, there are at least 3 units with in-house capacity, and therapeutic apheresis to ensure that we can support patients both in preparation for the sensitized patients and in instances where patients have rejection is also now available, within country. And the capacity to be able to also read graft biopsy histology is also now available in country. The results of that survey showed that specifically 23% of the patients, 23% of the units have the capacity to be able to do the HLA typing, in hospital. 40% of them have the capacity to be able to do the CNI drug levels within the various hospitals. Transplant biopsy histology is available in 45% of them, and 25% of them have the capacity to carry out plasmapheresis to support the transplant program. 20% of them have the capacity to do pediatric transplants. And the challenges they faced, one major one, which I've heard as a recurring theme through most of the presentations I've listened to today, is that almost 85% of them, the cost of the kidney transplant is out of pocket. Very few of them are supported by government, and none of them currently are supported by the National Health Insurance Scheme. And this brings challenges as to the cost of the immunosuppressive therapy, where 97% of them have to provide the cost of these very, very expensive medications out of pocket. And very few are supported by any of the government or National Health Insurance Scheme or NGOs on the long term. The challenges that were adduced by each one of these units varied from problems with convincing donors, and of course funding, the problems of laboratory support, personnel, and funding for most of the transplants. Very quickly now, I'll go through our experience at St. Nicholas Hospital. We have been doing dialysis since the year 1998. I set up the units 26th of August in the year 2000, in the year 1998. And currently, these are the numbers of de novo patients that we see every year. And in 2023, about 200 patients presented with end-stage renal disease in that unit. Out of these, majority of them were male. The average age was about 50 years, and 43 patients in that particular year had transplants. The transplants program has been supported over the years by units based in the UK initially, and later India, and currently the program itself, the last 5 years, has been independent of itself and completely indigenous in terms of the necessary skills to be able to carry out the transplant. In terms of numbers, these are the numbers that have been done over the years. And this is just in St. Nicholas Hospital, where I'm based. So in the year 2000, we did just 2, and progressively since then, the numbers have been increasing. And last year, we did 43 transplants. The youngest that has been done has been 11, the oldest 67. The mean age of our recipients has been about 46 years, and there have been thrice as many males and females. So 74% male and 26% female. The age range of our transplant recipients, generally, as you've heard from previous presentations, patients tend to be younger than similar patients in other parts of the world. So for some reason, our individuals are developing end-stage renal disease at much younger age. And I believe that that has a lot to do with the etiology of chronic kidney disease in our own environment. And similar to the statistics shown by Professor Antwi from Ghana, you find that the commonest cause has been hypertension, followed by chronic glomerulonephritis. But diabetes is an increasingly common reason why our patients also are developing end-stage renal disease. The donors have ranged from the youngest 18 to the oldest 70. The donors are slightly younger, and there's a tendency for there to be male donors rather than female. In terms of the relationship, as a policy, we're very strict about the relationship between the donor and recipient. And most of them have to be either emotionally or genetically related to the recipient before they're accepted as donors. And we go through extensive ethics assessment prior to accepting, both in-house, and we send to external ethics assessors. And then they also get sworn affidavits from courts and a recorded video of donor recipient professing altruism. We do some of the donor nephrectomies laparoscopically, either hand-assisted or full laparoscopic, and we find that leads to a shorter stay for the donors, fewer complications, and quicker recovery. And this is just one such donor the day after donation. Despite our having the capacity for almost 25 years, quite a number of patients still travel to other parts of the world, particularly to India. And this, in many instances, is because, very often patients that we have not accepted on account of the relationship between the donor and recipient travel to other parts of the world and get the transplants done with those donors that we may have rejected because we were uncomfortable with the stated relationship. Statistics, like I said, we've done 427 till date. 1 year graft survival has been 92%, patient survival has been 96%, 5 year graft survival has been 68%, and 10-year graft survival has been 36%. In terms of malignancies that we've seen, quite unlike the pattern seen in the developed world, the commonest post-transplant malignancy that we have seen has been Kaposi sarcoma. We don't see as much PTLD, and not as many skin cancers. Now, for the patients that have gone abroad, find that often the donors are non-altruistic, rejected, and they very often come back prematurely with multiple complications. They don't come often enough for review. Mortality is extremely high amongst them. And this is just one example of such a patient who was transplanted in Pakistan and ended up losing the graft within first 2 days after the transplant, came back on dialysis and eventually succumbed. It's important, and I know we probably will be having another webinar session dedicated to this, but it's important that we stress the need for us to adhere by the Declaration of Istanbul, which hopes to take measures to protect the poorest and vulnerable groups from transplant tourism and the sales of tissues and organs. I was fortunate to be one of the over 90 people that put that Istanbul Declaration together in 2008. And it's important that we try and adhere to that in our different practices. Consequent of that, Nigeria has enacted a health act, specifically dedicated to the act of transplantation. And there are penalties that have been stipulated for individuals who flout that act. The concern that those of us in transplantation have is that the penalties are not stringent or strong enough, and representation has been made to government to make sure that this becomes a lot more stringent. Government had set up a body, and the penalties have been reviewed, and we're awaiting the enactment by Parliament to make sure that it serves as further deterrent to patients who might be thinking of that. Secondly, we're also looking towards commencing a disease donor transplant. The necessary legislation has been passed, and the committee has been set up, which is looking towards ensuring that we can do this safely, within the country, to ensure that the pressures on live donor transplants and the risk for non-altruistic transplants are reduced. Now, in terms of solutions to what I think we should be doing to ensure that we can improve on transplantation in our region, we need to improve the quality of dialysis to ensure that we have suitable patients that would eventually qualify to have transplants. To do that, we have to increase the number of dialysis units. We need to increase the numbers of nephrologists, renal nurses, and technicians. We need to improve the quality of dialysis through training, change of attitude, and equipment. And we need to consider transferring our suitable patients to renal transplantation as early as possible. To improve that, we need to manage the patient's anemia properly and obviate the need to transfuse. Each time patients are transfused, we increase the risks of such patients becoming sensitized, and becomes a problem identifying suitable donors for such patients. Improve their nutrition, should avoid femoral vascular access, and it's gratifying to note that the capacity to be able to insert internal jugular tunneled catheters has improved around the country. And then, of course, we must manage our patients appropriately and prevent the risks of their developing hepatitis and manage those who have such hepatitis appropriately. But most importantly, transition these patients to renal transplantation earlier. It's on the long term cheaper to transplant than to maintain the patient on both hemo and peritoneal dialysis. And recognize that statistics have also shown that the shorter the time the patient spends on dialysis, the better the short-term and the long-term outcome in such patients. Then we need to improve the quality of transplant centers. As you can see from the data I presented, there are many centers that carry out just 1 or 2 transplants over several years. It's unlikely that such centers will be able to develop the capacity and experience to be able to do transplants safely. So should we be looking at collaboration between centers, looking at merging centers, or defining a certain number of transplants that a center should have done for it to be certified competent enough to do transplants? And then the association is looking at setting up or has set up a central registry, which intends to collate results and outcomes, and then continuously train, audit, and monitor the various established centers to make sure that they're carrying out the transplants safely. And then we can then think of, things like taking on the more complex cases, retransplants, and those that might have coexisting illnesses, comorbidities that might make the transplant process a little more complex. Then, of course, like I said, to ensure that we commence and expand the capacity to do disease donor transplants within the country. But it's important that we recognize that donors, we must accord them the necessary follow-up requirements to ensure that they continue to remain well, and as such encourage other potential donors in the future. We must ensure we guard against commercial kidney donations and enhance the local capacity to do the tests. But most importantly, we have to find a way to reduce the costs, because as had also been said by a few of the other earlier presentations, probably the commonest reason why a lot of our patients develop graft dysfunction and graft failure is because they cannot afford long-term sustenance of the immunosuppressive drugs that are required in such instances. And because all these drugs are imported and very often expensive, and patients are not able to sustain them, we need to look at relevant research. We need to indigenize our various programs, but we also need to focus on prevention, because it's going to be difficult for us to cope with the numbers that we have. I always leave with this slide, which is the slide of one of my earliest transplant patients. And this was a husband who donated his kidney to his wife exactly 24 years ago, and both of them continue to remain alive and well. So many thanks for your attention.
Thank you very much, Dr. Bamboy. Very, very inspiring and exciting talk as usual. Very lucid, clear for everyone to understand. So at this point, I'll hand over to my fellow moderator, who is going to take the Q&A session. Thank you so much, all the speakers.
Okay, I think all the presentation is open for a question, I think.
So am I allowed to ask questions as a moderator? Because I seem to have some questions.
Okay.
Okay, thank you very much, all the presenters. Very, very interesting to hear the amount of transplant going on, problems and opportunities that we can exploit. I have several questions. This is West Africa, and Dr. Ebon had mentioned the issue of APOL1 iris variants in West Africa. And our recent studies show that the prevalence of high risk may go as high as 40, 50% in some populations. So without checking APOL1 in patients, isn't it conscionable to ask a donor to donate kidney when the donor does not know the genotype, the APOL1 genotype? That is one question I have. Then the second one is, what are we asking our governments to do? Like some of you mentioned, especially Ebon, transplants seek out the money. CKD needs so much money. How an individual cannot pay out of pocket for transplant. And in most places, you find out people pay out of pocket. And we know that kidney disease is the most common cause of catastrophic health expenditure. So how do we get this sorted if we want to move forward with transplant? I'm an advocate for prevention because I know kidney replacement therapy is something most of our governments or most individuals can pay. So thank you.
Well, maybe I should attempt to answer the questions, and any of the other speakers can also join in after. Yes, I think worldwide, now that the risks attached to the apolipoprotein 1 gene is being well established, I think it's becoming imperative that it should probably be a routine part of the evaluation of potential donors in the process of
Dr. Bamboué,
transplant.
you have to close the second microphone. There is a noise.
Not from me. So yes, Professor Ulasi, I think it's vital that we look towards, establishing that. But the problem would be the routine availability of the capacity to do the apolipoprotein 1 genotyping and the costs. Already the costs of carrying out the transplant is such that it limits the numbers of people that can have access to it. As to what the government can do, I think one of the things which I hope when we get to East Africa will become evident is that the East African, in Kenya particularly, the government of Kenya actually has fully funded the cost of care. And that includes not just dialysis, but also transplantation, post-transplant care. I think governments need to realize that they're set up to care for their citizens. And as you've said, renal disease is one of the major causes of catastrophic expenditure when it comes to providing that care. So it's important that government has to find a way of subsidizing, if not fully taking over the cost. And I know that this had happened in Sudan sometime in the past, where Sudan would not cover the cost of the transplants, but would cover the costs of immunosuppressant medications. So if the government is able to purchase such medications in bulk, even if not to fully cover the cost, such bulk purchase would help to bring down the costs and hopefully make it sustainable for our post-transplant patients to be able to maintain, the cost of the immunosuppressive agents post-transplant. So there's no way that government will not have to play a role. But it would be interesting to know or to hear of what the other speakers might have to say as regards this.
Yeah, sorry. Thanks, Iban, for that answers. I mean, for me, like I've been said, if you look at the cost of transplant on the surface, we think it's expensive, $20,000. But as we all know, in the long run, it is cheaper than maintaining somebody on hemodialysis. And so it is discussion that we all need to have with our governments to support transplants, local transplants. And I see that once we build local capacity and we have people, local surgeons, urologists, being able to offer the transplant here, of course, we eliminate the cost of travel and all those kind of things. So it is a bit better. But the challenge will be the immunosuppressants. And that is where I think government can come in to support. If we finish transplants, particularly local capacity, we build these ones. Well, maybe a bit costly, maybe cost sharing. If we can go the way Kenya has gone, great. But even if it is subsidized, it's better. But the key thing is with the suppressants, which we must fight. How many people are we transplanting who are going to be on suppressants? So we need to fight to get that one probably be absorbed, because that will be the challenge. Otherwise, it is costly. Even those who travel outside go and do the transplant, but we can't sustain with the suppressants. Then, your prognosis is guarded, and so it is an area that we can't really engage government, that even as people are able to do transplants for whatever resources that they have, government must actually meet them halfway here. This immunosuppressants, government should do something about it. And either it's absorbing completely or it is subsidized. Subsidy is the way to go. We need to fight, because if you look at the people who need transplant, those who are being transplanted, what is their numbers compared to other diseases? So we will need to look at subsidies, either for the transplant itself. If you do in-house or in-country transplantation, definitely the cost will be down. And also, if the immunosuppressants can be taken up by government. So let us all get engaged government as we try and expand this service of transplant in Africa and West Africa. That is what I would say. Thank you.
I can see a few questions from the chat box. One is from Jacqueline, who says, to Ghana and Nigeria presenters, what drugs do you use for induction pre-transplant? When do you start immunosuppressants pre-transplant, before or after transplant? We start immunosuppressants a week prior to the transplant. And for induction, we use ATG and methylprednisolone. In the early days of our transplants, we limited this to just what we felt were the sensitized and high-risk patients. We found that by doing this, we've reduced the risk of acute rejection, and the outcomes are much better. So we use ATG and methylpred for induction, and we start the immunosuppressants a week prior to the transplants. The other question I see from the chat is, patient survival was better with cyclosporin than tacrolimus. I think what studies have shown is that short-term outcomes are better with tacrolimus, but long-term are better with cyclosporin, because tacrolimus tends to be slightly more nephrotoxic than cyclosporin. But in terms of preventing acute rejection, the outcomes are better with tacrolimus. When we started off our program, we started off with cyclosporin, and many of our older patients remain on cyclosporin and continue to do quite well with cyclosporin. But more recently, we switched to tacrolimus, and we're yet to see the long-term effects of it. But I think most programs now have switched from the use of cyclosporin to tacrolimus. Also, in the early days, we used azathioprine, or more recently we've switched to mycophenolate or CellCept. The challenges of that, of course, are that both tacrolimus and CellCept are a lot more expensive than cyclosporin in replacement of tacrolimus and azathioprine. And there have been instances where, on account of costs, when patients have now been unable to sustain the costs of particularly the CellCept, one has had to switch from the use of CellCept to azathioprine in replacement for the CellCept or the mycophenolate mofetil. How do you manage the risk of transplant tourism? I mean, for us in my hospital, first of all, we don't transplant people that come outside of the country. All our patients have been Nigerians. The only two instances of non-Nigerians have been two Ghanaians over the years, and both came. One was a Ghanaian based in Nigeria, whose brother, also Ghanaian, donated. And the second was a young lady from Ghana, also working for Dangote, which is a Nigerian company in Ghana. And she also came with her sister as a donor. So one thing we avoid is having people come from outside of Nigeria to come and do transplants. I think that's one major way of stemming the risk of commercial transplant tourism. But it would be interesting to hear of how other groups have been able to manage with this.
I think, Dr. Bomboye, that we will dedicate one of our next webinar to how to prevent tourism transplantation, and we will see with the Declaration of Istanbul Group to participate, to organize this webinar.
Yeah, I think we had decided that that would be, but it's increasingly becoming evident that it should come earlier rather than later.
So if there is no more questions, I think that we can close the webinar. So at the end of this webinar, the third webinar of the Afghan Transplant Committee, dedicated to the situation of kidney transplantation in West Africa, and in behalf of all the members of our committee, I would like to thank all the speakers and moderators, all participants, of course, and the organizer of this webinar, Dr. Mariam Khavar and Professor Gamal Saadi. We look forward to see you in December 20 for our first webinar with a very, very interesting topic, acute rejection after kidney transplantation, what's new? And we will have during this webinar 3 communications about immunological update, histopathological update, and therapeutic update. So thank you very much again, and see you soon.
Thank you.
Okay.